Mindoula helps primary care practices meet the many challenges of behavioral health. And by that, I mean, not just identifying those that need the help, but also providing access to that help while offering some significant revenue opportunities to your practice. And Mindoula does so with a model that doesn't put a big strain on you or your team. So it's my pleasure to introduce James Dold of Mindoula to walk through a few slides and present to you what Mindoula brings to the table. James?
Hey, Keith. You guys hear me all right?
Gotcha.
Fantastic. Next slide would be great. Next one. It's nice that we're going to actually hear some continuity and some themes between the vendors that the PA Clinical Networks has actually chosen to work with. So from Mindoula's perspective, we're the national leader in the delivery of behavioral health services from the collaborative care perspective. We built our program learning how to manage the most complex patients with behavioral health needs in the community. And when we decided to launch collaborative care, it was a simple process for us of kind of backing off of the acuity tier and learning how to engage with patients in the mild to moderate category. But my question is really simple. Next slide, because I try to hit home. Right. So we'll get into the details here in a few minutes, but from a dollars perspective, there's about $3,000 per provider annually on a per patient basis. And we're seeing consistently between a 40 and 60% reduction in total cost of care across the board. In addition to that, and arguably as important, significant SDOH reduction from a burden perspective at the practice level, which leads to a happier practice, not just for the providers, which is of paramount importance, but also for the patients, because they have a resource now they can go to in real time and get solutions solved for in very fast order. But let's talk about the benefits really quickly. Next slide, please. We addressed the behavioral health needs for the practice as a whole, not just the ACO. We're available 24/7. So when a patient has a need in the behavioral health arena, they're not going to call the practice. They can call us, and we're available for them 24/7. After you make the referral, we're outreaching within 2 business days. There is no limit to the number of patients we can take because this is all virtually done. And if it's an older population, it works just as well over the phone as it does with a smartphone. We actually integrate really well with existing resources. And if you have other care management sources of opportunity within the ACO or within the practice, part of my job is to work with operations to streamline that process for everybody. And much as the other programs, whether I see the patient 2 times a month or 26 times a month, the patient only has a single copay on a monthly basis. So we have a very high engagement rate with our patients at the practice level because there's a lot of inherent value in the services that we offer. Next slide. Really quickly, the care team here is of paramount importance, and you heard this again with the RPM. The goal here is not to engage or interfere with the work that the provider does with the patient, but bolt onto the side of that relationship. Our virtual care manager will be doing the majority and all of that outreach and coordinating with the practice on an ongoing and as needed basis. We leverage all 3 of those opportunities in that peach bubble, our registry, our virtual psychiatrist, and our care management staff to form a bubble around the patient and provide their behavioral health needs with not just resources, but actually solutions. And if they fall outside of that continuum of a mild to moderate and are more severely acute, I tell everybody the very same story. Don't overthink it. Refer all the patients you have a question about. Let us triage and evaluate them. If they're appropriate, we'll enroll them. If they're not, we'll hand them off. But if they're too acute, we're not going to throw them back unless they're, actively suicidal, which has an entirely different workflow. But we'll say, okay, you know what? James Dold is too acute for collaborative care, but we're going to enroll him and actively work in the community to find him resources that are a good fit. And while we're waiting for those appointments to become available, we'll keep working with him from a collaborative care perspective and try to keep him put together until we can get to that next level of resource. Next slide, please. Again, a consistent theme. The goal here is to be as simple as we can for the providers, because as you've heard, you got 1,000 things. I'm a huge advocate for primary care. Having built the network here in Boston with Tufts, providers have 1,000 things happening every day, every hour of the day, right? So it's easy. We use validated assessment tools. Our recommendations may or may not involve medications. And the goal here is to communicate back to the provider as quickly as possible, usually within 10 days of that referral coming out. Next slide. So to make it really simple, again, refer, review, write for the prescriptions as requested, and then submit the billing on a monthly basis. And what we see, which is similar to the other service line, about $40 or $50 per patient from a new code's perspective will stay with the practice. Next slide. So let's think about this at scale. I tell everybody the very same story. The behavioral health needs at the practice level run as high as 40% in a primary care practice and as high as 70% in a women's health practice. It's a daunting idea to get your head wrapped around. You shouldn't be referring 5 patients a month. You should be referring 25 or 30 patients a week if you can, because the impact is so great on your practice. So if we have 100 patients enrolled in this program active on an ongoing basis annually, there's about a $300 opportunity between two things: the net of the codes, which are $40 or $50 per patient per month. And we also see a 0.3 coding pickup on the behavioral health side of the coin, that when you have the opportunity to right size your population 4 times a year, you'll see about a $225 per month increase in the opportunity at the practice level, because you're clearly and accurately coding for these patients and their behavioral health challenges. As I mentioned earlier, Privia, one of our longer standing partners, is showing consistently across all of their markets a 40 to 60% reduction in cost of care, right? And so from an ACO perspective, yes, there is opportunity here from a cost perspective for these patients in your ACO, but if I can shave 40% off of the total cost of care for your most acute patients, our length of service is between 5 and 7 months. That's a significant uptick in terms of the revenue opportunity at the practice level. Next slide. And this is actual data from an ACO I've been working with in the Mid-Atlantic. And I was providing this to them on a monthly basis as to what does their panel of patients look like and where's the opportunity for them to get engaged. I tell everybody, I'm a behavioral health nurse by training, ER nurse after that. It can be as simple as any patient with 2 or more chronic conditions. The data is spectacular. Any patient with 2 or more chronic conditions is 3 to 5 times more likely to get depressed. And when they get depressed, your value or your expense to manage that patient goes up significantly. And so here we're looking at patients with 2 or more chronic conditions as a flag, and patients with depression or severe mental illness as a flag. And again, we can slice and dice the population any way you want us to work with you, but the opportunity from a coding perspective and from a net new revenue on this new codes that you'd be billing is significant. Next slide. Same practice, right? I did a really quick, non-scientific study, but I matched the top 10 chronic conditions, patients with depression and patients without depression. And what you see in that red box is the bottom is how much they're spending on the management of those patients with those chronic conditions after they get that depressive diagnosis tied to it. And the average is 276% more to manage those patients with those chronic conditions, in addition to a depressive diagnoses that are tied to it. And again, next slide would be great. And again, the goal here is to make it simple. This flows into your EMR on a per patient basis. It has the assessments we're working on with the patient, their progress to goal. On the right side of that document is the psychiatrist findings, his or her medication recommendations, the diagnostic recommendations. So you're seeing that coding pickup. And most importantly, bottom left, there's not a yellow box on this version, but the psychiatrist's direct email and cell phone, right? So I recognize writing for psych medication is outside of the scope or the wheelhouse for most primary care providers. It's a very uncomfortable space, at least initially. This allows 2 things. You can get your hands wrapped around the entire needs profile of the patient by leveraging a consulting psychiatrist. And every provider I've worked with in the 28 states we're doing this today, at the 90-day mark, when they've enrolled, a couple of dozen patients in a program like this, they wonder how they did it for so long without having real-time access to a consulting psychiatrist at the end of the phone or the end of an email thread. And I can stop there for questions or concerns or comments.